The broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody. Welcome to today's PBIC webinar. This will be the final installment in our PBIC Health and Transportation webinar series. So we're excited that you're joining us. I hope that you've been able to join some of the other episodes in this series that we've held over the past couple of weeks. We have today a really exciting, I think, a really exciting way to wrap up the series with an excellent panel. Really more of a discussion today than pure presentations. We're going to handle a lot of questions that have been raised from the previous episodes, all with the ultimate thrust of how we can leverage some of these health goals and health priorities into policy action and bring public health to the transportation policy table. So it's a great time for you to be here to share the questions that you have with us. We will have plenty of time to answer those. And so at any point during the presentation, please don't hesitate to submit a question if you have one for our panel. Before we get into the presentations, I did want to go through just a few housekeeping items. As attendees, you won't be able to speak, but as I mentioned, you do have that ability to send in questions along the way, comments, reactions, anything you'd like to share with us that I can share with our panel. Please do that at any time using the questions pod. We'll be recording this webinar and we'll be posting that shortly to our webinar archive page. And we've already posted a copy of the slide deck. We do have some slides, so if you'd like to refer to those are online for you. I'll be following up later today with an email that has a link to the archive page. It'll have a link to instructions to download a certificate of attendance for the webinar and a few other pieces of information about professional development hours. If you're a planner and you want to claim AICP credit, we've had the webinar approved for 1.5 CMs, so you can look on their event calendar for that information. I'd encourage you to visit our archive page and look at the recordings of the previous episodes if you did miss them. There's some great information shared by our panel on these various topics that you should see here on your screen. We've covered quite a lot. Everything from looking at how decision making is happening in our communities and confronting the power and privilege behind those decisions, talking about agency structures and partnership, collaboration, integrating health data, planning and prioritizing projects. Talked about that yesterday, and so we're here to really think about policies moving forward and how we can turn some of this work into action. We all know that transportation and health do intersect in many ways, and our infrastructure and transportation services and the designs and the policies around those have been identified as key factors in determining health status and outcomes. This report, NCHRP Report 932, served as a basis and motivation for this series, and we wanted to continue asking some of the questions raised during that project about how we can define and capture health inequity in transportation practice, and in what ways we as transportation professionals or health professionals might work better together to accomplish some of these goals. There are many different pathways that transportation practitioners can take to improve public health, and in this series we've been discussing the ways that agencies are examining, who is at the table and has power, how they're partnering with other organizations, how data can be integrated, and how to change processes and practices related to project selection. We're going to center on developing and forming more health-oriented policies today. And I want to introduce you to the panelists who are joining us so that you can get to know them a little bit, and then they're going to follow that up with some opening remarks of theirs. So before we get too much further, let me go ahead and introduce them one by one. Roy Gothi is with us today. He is the Pennsylvania Department of Transportation's statewide bicycle and pedestrian coordinator. He has 11 years of experience in the transportation field, working in planning, programming, and policy, as well as his current involvement in active transportation. And in his capacity with PennDOT, he works with a wide range of internal and external stakeholders to craft policy and legislation, provide educational outreach, and facility design guidance that allows the department to utilize innovative roadway design standards and significantly improve safety for all road users. We're very excited to have Roy with us today. I'd also like to introduce Megan Weir Megan Weir is, the Safe Streets Division Manager for the City of Oakland's Department of Transportation, and oversees the bike and pedestrian program, traffic engineering, traffic maintenance, and signal operations teams to strategically advance a safe, equitable transportation system for the Oakland community. And prior to starting at OakDOT in early 2020, Megan was the director of the program on health, equity, and sustainability at the San Francisco Department of Public Health, where she worked for over a decade at the intersection of health, equity, and transportation in partnership with city agencies and community stakeholders. We're delighted to have Megan with us today. Wendy Landman is also with us. Wendy is a senior policy advisor at Walk Boston. She served as executive director of Walk Boston from 2004 to 2019, where she led the organization's growth into a statewide advocacy presence with leaders in state and municipal government, the nonprofit community, and community-based organizations. Key programs underway address Vision Zero, age-friendly communities, rural walking, and multimodal transportation policies. Wendy currently serves as board vice president of America Walks. So welcome to Wendy as well. We're also joined by Karen Whitaker, who is vice president of government for the League of American Bicyclists. Karen leads the League's federal policy advisors to secure bicycle and pedestrian friendly policies and funding through advocacy with Congress, the administration, and national advocacy partners. Before working on transportation policy, Karen worked for the National Wildlife Federation on smart growth, international policy, and community engagement. In addition, Karen served as community land use planner for the state of North Carolina Division of Coastal Management, providing technical assistance to local governments and staffing a stakeholders council responsible for revising state planning regulations. So we're very happy to have Karen with us today. Finally, we're joined by Renee Autumn Ray, who is an urban planner who has worked in transportation and public health, planning, policy, operations, and data evaluation. She focuses on barriers to access based on disability, income, or race, and she's worked at local and regional agencies and for United Healthcare, CDC, and Federal Highway Administration. She currently leads innovation and strategy for Conduent Transportation, a technology company which includes payment processing, enforcement, and data analytics for transit curbside management, road usage charging, and public safety. So I'm so happy to have Renee, all the rest of our panelists with us today. We're going to kick things off with some opening remarks from each of our panelists before we move into more of a discussion. And so Roy Gothi, I'd like to ask if you could turn your camera on and welcome to you and begin some of your opening remarks.
Oh, thank you very much, everyone, for your time and attention today and the invitation to speak. In Pennsylvania, as the statewide bicycle pedestrian coordinator, I'm working with 67 counties, 958 boroughs, and 1,546 townships of all different sizes. And my job there is to make sure that the people working there, the elected officials, have the information and the tools they need to make the best decisions about their community. And as it said in my bio, I work with a lot of stakeholders. So internally at PennDOT, our staff, our friends in the state legislature across the street, leading them forward step by step. And the slide we have here is the title slide I've been using for the past, our active transportation plan, which is really the point for PennDOT getting its toes into the water with health and transportation. For the first time ever, PennDOT has a plan that talks about the linkages between equity, community health outcomes, active transportation, walking, biking, and rolling, and economic growth and environmental health. So we pulled these in. We created an executive summary and a how-to guide. We've updated our web pages to reflect a lot of this information to guide people deeper into the topic if they wanted to go there. And the point being, we're starting the conversation in each of the 67 counties. How do you imagine your community looking? These are the things that you might want to consider as being important to your transportation network, and here's how we can help you do it. I think the other big piece with the active hand in glove work with our Department of Conservation and Natural Resources and our Department of Health as they revise their 5-year plans as well. So a lot of the action steps overlap. They touch each other within each plan. And we have a very strong relationship cemented with an MOU to continue ongoing work supporting walkable communities moving forward. So that's the basis where I'm coming from for the presentation. Thank you.
Thank you, Roy. Really appreciate having you here. We're going to shift to some remarks from Megan Weir now, Oakland Department of Transportation. Megan, if you'd like to come up, let me get your slides going. All right.
Thanks so much, Dan, and thank you everyone for the opportunity to participate in today's discussion. I'm really excited to be here and just wanted to start with an overview of really where I'm at and what I have the opportunity to contribute to and where I've also been coming from working at the intersection of health and transportation for over a decade. And after Oakland's slow streets corridors and then the Essential Places program to address really the physical and mental health needs of residents during shelter in place in our slow streets corridors, our soft closures that are creating more space for physical activity during COVID-19, but also we heard really clearly after we launched that program that the program was really well received by a number of residents, particularly among more affluent communities, that the needs of communities of color and our lower income communities were not necessarily being met by that program. And we pivoted and launched our Slow Streets Essential Places program, which focuses on temporary traffic safety improvements at the locations such as grocery stores, food distribution sites, public health facilities, and other test sites that are really often also located on our high entry corridors in Oakland to address the needs of residents during the pandemic. Next slide. And there's a link at the bottom of this slide. Next slide, please.
Yeah, sorry, it's a little slow coming across, Megan.
Thanks, Dan. No worries.
My apologies.
No. Also, really a theme I think that's really important for this discussion today is the kind of the old adage that what gets measured gets done. And the Oakland Department of Transportation has a really amazing geographic equity toolbox that's been developed to really help spatial analysis of where priority communities, including communities of color, low-income residents, people with disabilities, seniors, and other populations are concentrated so that transportation policies, plans, and programs can really help meet the needs of communities that have been historically underinvested in transportation decisions. Next slide. And I, coming from a public health background and just acknowledging the awesome webinar series that we're embedded within, I also felt like I'd be remiss without sharing some public health frameworks to really understand the comprehensive way in which transportation and other policies that impact land use, housing, and other factors really impact on multiple health outcomes of residents. This framework was developed by the Bay Area Regional Health Inequities Initiative, and at the left we can see how social inequities are really embedded within the living conditions that we all live on and ultimately shape health behaviors and injury and mortality in these systems. And the bubbles at the bottom in blue and also in orange really emphasize the opportunities to intervene in partnership at all the different levels of this framework, and policy in orange really being a critical tool for that work. Next slide. Too many graphics. Thanks, Dan.
Sorry for the delays, Megan. I think it's on my end.
No worries at all. Thank you.
It's coming. It's coming through the internet.
Okay. say anticipation. And so I also wanted to give a shout out to the overall concept of health and health policies, which is really a collaborative approach to improving the health of all people by incorporating health considerations into decision-making processes. And really all transportation policy is health policy and impacts on the health of our communities. Our next slide also is really focused on, I'll start talking about it in advance on health impact assessment, which is a really important tool that has been used in to address the effects of many policies, plans, and programs, and understand both the health effects and how it's distributed across populations. At the bottom, for those of you who are interested, there's a number of examples of how health impact assessment has been used to assess transportation policies and also make recommendations to either maximize health benefits or minimize any negative health benefits or health impacts. And I also wanted to mention, over a decade ago, I attended my first Transportation Research Board meeting, at which it wasn't uncommon to be in a room where people were asking, what is public health and do they keep trying to get at the table? And so I'm really excited, now that the Transportation Research Board actually has a Transportation and Public Health Committee. And this slide depicts a number of ways that those of you who are interested more on the research side and how research can ultimately impact transportation policy and public health opportunities to get involved. This slide depicts a really rudimentary diagram that I created a number of years ago, but I also felt was really salient to to today's discussion in understanding that data and tools and evidence and clear goals are critical, but are never sufficient. And so having really explicit policy targets that are informed by evidence to advance health and transportation goals, but also having the right stakeholders at the table, but also the larger context, the need for political will to move the needle towards a more healthy, equitable society. And I want to round off my opening remarks with just some comments on Vision Zero, where in my previous role, I had the opportunity to co-chair the health department in San Francisco co-chairs the city's Vision Zero initiative with the transportation agency, and just wanted to really emphasize Vision Zero transportation policy is clearly aligned with public health goals, with a focus on the most severe health outcomes of the system, a focus on speed and creating safe streets, safe people, and safe vehicles, advancing health and addressing and creating a safe transportation system. And for today's talk, I also really wanted to focus within San Francisco's Vision Zero strategy. On the left is the framework of advancing strategic local actions as well as transformative policies, many of which require state legislative change and complementary goals. And underlying that entire approach has to be a focus on equity in order to address health. And within transformative policy, really focusing on policies that will move the needle on slowing vehicle speeds as well as reducing vehicle miles traveled. So examples for speeds including lower speed limits in urban areas and automated enforcement, which have really demonstrated public health benefits. But also that on the next slide, really talking about the importance of within any local, state, or national context, thinking of how initiatives that are really focused on clear goals such as Vision Zero can work with other goals that we have to create safe, healthy, equitable communities. And so within Vision Zero, as Vision Zero actions are advanced, ensuring that they're consistent with and are also advancing goals for our climate crisis, to address public transit, to encourage mode shift, and also to address our housing crises. In my last slide, really just the importance of for any health and transportation goal, the need to address inequities in our transportation system in order to achieve those goals. So injury is just one example, as is our current COVID-19 crisis, where the communities that are the most impacted by adverse health outcomes are also the same communities where we see higher concentrations of low-income residents, communities of color, seniors, and people with disabilities, and where we need to prioritize our transportation resources. So that concludes my opening remarks. Thanks so much, and really looking forward to this discussion.
Thanks very much, Megan. I apologize for the slowness on the slides, but we'll be sure to bring you back to the discussion in just a moment. I want to welcome Wendy Landman now. Wendy, if you want to come on camera, I've got I'll put your slide up, and there it is, whenever you're ready.
Okay, great, and thank you, and good morning or good afternoon, everybody. I'm really pleased to be part of this panel. I wanted to start by saying that Walk Boston has been around for 30 years, and we started with a focus on the Boston metro area, and now work all across the state. And as you can see by our mission statement below, we have been focused on this pairing of better health and walkability, or transportation, in our work for many, many years, really since the start. And just on this slide, you just see a couple of the brochures that we used to use more often when we were out and about in communities and thinking about how to put together safety and health. And our work is really both top down and bottom up. We do a lot of work with many different state agencies to encourage them to both incorporate walking and walkability in the work they do, but to pair that with the way they're thinking about equity, the way they're thinking about health. And we also do a lot of grassroots work, both with community-based organizations and individuals, and also with municipal staff, to make sure that the things that we're trying to get embedded in policy at the state level are actually being acted on at the municipal level. For many years, I think the focus of our work was really on two parts of the transportation and health system, which is physical activity and injury prevention. I think the pandemic and the focus on the inequities that it's revealed in our society has really pushed to the forefront some additional pieces of that puzzle, namely air quality and emissions and their impact on health broadly, and transit and access to transportation systems for everybody in society. Next slide, please. So one of the things that I think is critical is that the work on transportation and health cuts across every kind of community. This happens to show the places in Massachusetts where we work. Eastern Massachusetts is very urban, Western Massachusetts is very rural. And in both of those settings, transportation and health are inextricably linked to the quality of life for the people who live in communities wherever they are. And I just wanted to mention two of the key data points, I guess, that we use a lot in our conversations with people to point out how important this pairing of transportation and health are. First, the fact that people that take transit to work are 50% more likely to build the physical activity that is needed into their day just by walking to and from transit, and how important that is that we think about walking and transit paired as a critical health input. And second, that even when you control for demographics and income and all the usual points about socioeconomics, people who live in walkable communities are less likely to have diabetes or to develop diabetes than people that don't live in walkable communities. Next slide, please. So one of the things that has been happening in Massachusetts, we have been putting health and transportation together in Massachusetts for quite a while. There was something called the Healthy Transportation Compact that was put in place in 2009 under the Transportation Reform Law, and that required multiple state agencies to work together on transportation and health. And that was helped spur a lot of action in the state. So I listed a few of the things here where there is a combination of transportation agencies, public health, and many often advocates, service providers, and many others working together. I wanted to mention just really quickly 2 of them, Mass in Motion, which is a program of the Mass Department of Public Health that is focused on healthy eating and active living and provides support and funding to about 60 of Massachusetts cities and towns. Mostly those that were selected have the highest health disparities in the state. And this is where they're working with municipal agencies, community-based organizations, and have somebody placed in the community that's supporting the combination of active transportation and health in those communities. And the second, the most recent, in response to COVID-19, MassDOT, the Department of Transportation, launched the Shared Streets and Spaces program that put about $10 million very quickly into a grant program, all of which has now been expended. They're considering perhaps adding some, but to support all kinds of mobility improvements and local economic development activities. And that funding, about 60% of it went to transportation justice communities in Massachusetts. So I think thinking about equity and pairing health and transportation is something that has started, and it's usually focused on health data or income or other proxy data for transportation justice communities. Next slide, please. And Walk Boston works at the very grassroots level. So we've put together our greatest hits for age-friendly walking. That's a program that we're spending a lot of time on these days. This happens to be about infrastructure. We have another for local municipal policies. And just to point out, one of the things that has come up as a result of COVID is some attention being paid to very low-income senior housing, much of which has no access to outdoor space and no good walking access that links that housing to civic facilities, to libraries, to shops. And so we're beginning to do some work in communities to try and be very explicitly thinking about how to make those connections at this moment in time. Next slide, please. And just to talk a little bit about what we still need to do. And these are really big picture things that we still need to do. So getting to reduction of GHG emissions from transportation. I think that the pandemic has put such a sharp focus on air quality and the impacts of the transportation system as a whole, which in Massachusetts is the biggest contributor to GHG and particulates, and how critical it is to work toward mode shift, and to work toward the electrification of fleets and vehicles. And one of the things that's being called for now with increasing intensity is better air quality monitoring, targeted air quality monitoring with follow through. A second piece is investing enough money in transit to ensure that transportation is there for essential workers, for low income communities. And I think this is obviously a piece of the national conversation, and maybe Karen's going to talk about that a little bit, but it is very, very clear in Massachusetts that we are not doing what we need to do in terms of thinking about how transit is actually a component of the public health system. And finally, at the very local level, thinking about how we fully fund transportation so that our sidewalks get shoveled in the winter, at least in snowy parts of the world, that we're putting shade trees along sidewalks so as the planet warms up, people can continue walking year round, and really thinking about investing in fully accessible networks of sidewalks and safe crosswalks so that people can keep walking and can age in community in a healthy way. Thank you so much.
Thanks so much, Wendy. We look forward to bringing you back in during the discussion period. Thanks for sharing that. I'd like to turn it over to Karen Whitaker now. Karen, if you want to put your camera on, you can go right ahead and I'll put your slide up.
Great, thanks. So I spend most of my time working with Congress, talking about transportation policy and biking and walking within it. We are right now looking at expanding our work on health policy. So I'm really excited to be part of this conversation. I want to take a couple minutes now to talk about the advocacy side of that, though, and how we can work better with health advocates as we're talking to decision makers about the relationship between transportation and health. So I'm going to talk about two different coalitions that we're working in and what we've learned in those. The first is this Transportation Alternatives Coalition, where the majority of groups are not transportation groups, and I would say about 2/3 are health organizations. We lead the coalition with the Safe Routes Partnership and the American Heart Association. And our goal is specifically to increase funding for the Transportation Alternatives Program, but also just active transportation in general in the transportation bill. But some of the lessons we've learned with working with the health community are similar when you're doing advocacy with any community. It's sort of to meeting them where they are. And then part of that is learning their language and how they think about active transportation. In the transportation world, we talk a lot about the safety, biking and walking safety as key. That doesn't really resonate with folks who are worried about physical activity. And we can all, you know, make the argument that you have to feel safe in order to be more active. But when working with health groups, in trying to, especially when we're first trying to bring them involved, or to work with stakeholders, elected officials who care about health, we really need to think about that, more focusing on those words of physical activity and less about safety. This coalition has been around for about 6 years, and this was the first year we've really gotten them to be willing to endorse a safety bill. And that was because of all that work we've had leading up to it. The other big lesson is being strategic in what you ask them to do and making it as easy as possible for them. I think, you know, we all see the value in really understanding the connections between health and transportation policy, but working with folks who know, who get that connection. This group really, we do one in-person meeting a year, and the rest is they're like, tell me when to show up and what the talking points are, who I'm talking to and why. And so really trying to make it as easy as possible. Next slide. The second coalition I want to talk to is one that's focused on increasing CDC funding for state departments of health, county departments of health, places like that, to really encourage and talk about what they call active friendly routes to everyday destinations. That's how they talk about active transportation. And this coalition, it's pretty much led by the YMCA. And some of the lessons here, and one of the reasons it's led, say, by the Y instead of necessarily a health group when we're talking about health funding, is that we have to remember that the health community is as big and diverse as the transportation committee is. If I want to pull together a lobby meeting on biking and walking, and I'm going to bring in a transit person, I need to prep them on that. And my ask on biking and walking is not going to be their top ask. When we're talking about health groups, even though we know that connection, and that connection that we're just talking about between diabetes and physical activity, a diabetes group is going to be more focused on the line item about diabetes research or funding for diabetes. And so when it comes to physical activity, there's not really a health community that leads there. At least that's what we found at the federal level. And so part of what our community can do, especially if we want health advocates to help us in transportation, is to help them in the health world and help to, if not lead, but be willing to be the foot soldiers on physical activity and talking about the benefits there. Finally, I just want to point out the website at the bottom, data.bikeleague.org. Another part of the league actually gets some funding from CDC to do the benchmarking report on biking and walking in the United States that compiles all of the usage and health data we have on biking and walking. We have a new website now, which makes it a lot easier to access and to compare how your state or your city is doing compared to others. Next slide. And because I can't stop myself from talking a little bit about policy, I just want to talk about what these programs are that we're promoting through the Active People Healthy Nation Coalition. One are SPAN grants that go to the State Department of Health for physical activity and nutrition. This is a competition, only 16 states get funded. And so this is something we'd like to see expanded, especially to states that may have higher obesity rates, things like that. The high obesity program specifically works in counties where 40% or more of adults are obese or have obesity. And then finally, We've heard a lot about equity, and that needs to be transfused through all these programs. But we're also specifically trying to raise funds for this program for the racial and ethnic approaches to community health, which is working to reduce health disparities among racial and ethnic populations that have the highest burden of chronic disease. So looking forward to the discussion. Thanks.
Thank you very much, Karen. We'll have one more person, Renee Autumn-Ray, come on and provide some opening remarks before we transition to discussion. So just a reminder to everyone, please have your questions coming in if you have them, and we'll get to them in just a moment. But Renee, the floor is yours.
Great, thanks. Good afternoon, everyone. Very excited to be here and have this discussion today. So it was mentioned in the introduction, I'm an urban planner by training. I originally started in land use, but quickly made a transition to public health and transportation planning. Early in my career, I was working for a small town, the city of Tupelo, Mississippi. The mayor came in on a public health platform, so I thought if I can explain to him how my pet interest in walking and biking are related to public health, maybe he'll let me work on some fun projects and spend my time the way I liked. So that was really my start working in planning and public health. I spent about 5 years both in local government and as a contractor for CDC and federal highways, and really was focused more on the policy and planning aspect of it. But when I left there and took a job with the Atlanta Regional Commission, which is both the MPO and the Area Agency on Aging in the Atlanta region, I had basically transitioned from that skill set of knowing about public health and planning into more service delivery and transportation services for older adults and people with disabilities. And it was a really fascinating and eye-opening application of, how do the plans and the policies we put in place actually translate into increasing access for vulnerable users in a variety of modes, whether we're talking about something like paratransit or demand response transportation, or what does it mean to have a sidewalk plan and to make sure that there are safe access for people to be walking to bus stops or just to essential places in their neighborhood. I really became interested more in the technology facet of both planning and service delivery for transportation, because there is so much money being spent to invest in what the future of transportation looks like, that I felt that it was important to have more people in that piece of the transportation industry that understand human services and vulnerable users. So the company that I work for now focuses on payments and enforcement, but if those of you in the transportation field have been hearing about mobility as a service, a lot of the issues around that are with how do I find a trip, how do I plan my trip, and how do I pay for it? So there are a lot of policy questions and political consideration that goes into what the future of transportation looks like, how to make it easier for people, and how technology can be part of the transportation system a little more than it has been. So basically when COVID hit this spring, I sort of distilled all of the things that I'd learned over my career into a white paper, which was published through the Eno Center in July. And I think there's going to be a link to that paper that gets published in the chat at some point during, thank you, okay, I see it in the chat now, during this discussion, but basically was, okay, we are very likely, as we deal with this pandemic and try to understand what is happening in our own communities, how we're going to respond to this terrible public health catastrophe, and not just the public health aspect of it, but also the many ways in which state and local governments, which have to balance their budgets, are going to respond and react to the changing economic uncertainty. So the piece that I wrote for Eno Center has some very practical and incremental suggestions for what policies could be enacted or what program services could be changed at the federal, the state, and the local level to do a better job of joining together the mission of both transportation and health departments to care for the health, safety, and welfare of their constituents, the citizens, the people that are in the jurisdiction that they work on behalf of. So that's a little summary, and I'm excited to be here this afternoon.
Thank you so much, Renee, and thanks to the rest of our panel as well. As I transition us to the discussion period, I'll ask our panelists to bring their cameras up, and we're going to move now toward really somewhat of a reflective discussion period before we start responding to some of your questions, because all along the way throughout the episodes in this series, we've worked with our panelists and attendees to really bring up some questions from those sessions that really have a bearing on policy. So we're going to try to revisit some of the themes we've covered in some of the other episodes and ask our panel to weigh in. But I think it would be, and as a couple of our panelists alluded to, it would be inappropriate for us not to talk a little bit more in a webinar on health to talk about COVID-19 specifically. And as has been mentioned, we've seen that COVID-19 has really exposed and exacerbated many health disparities that already existed in our communities. And I wanted to ask how your agencies and organizations have worked to expand opportunities for active transportation amid the stay-at-home period and even now, and how might transportation policies address concerns that are now front and center in many communities. And I know Megan touched on some of the things Oakland is doing. I wanted to just ask you all to weigh in on that, if you don't mind.
Thanks, Dan. I'd be happy to speak a little bit more about our experiences in Oakland and the transportation agencies, our response to COVID-19. So, initially in the initial days of shelter in place, we heard a lot of demand for support for more space for physically distant active transportation. So we're seeing crowded sidewalks. We know that travel was one way people could get out of the house, and the many physical and mental benefits of physical activity. So we launched our Slow Streets program. In my slide deck, it does include a link for those who are interested, and ultimately have implemented soft or partial closures on about 21 miles of streets in Oakland. And we did a lot of work as a part of that program to also evaluate, how the corridors were being used, who was using the corridors, and also engage residents as we rolled out subsequent corridors. But a huge lesson learned from the initial feedback that we received were definitely that there is some real disparities in how the corridors are being used, and that more affluent communities who are home during shelter in place were able to use them much more, and that in lower income communities of color, communities where there are more essential workers, they weren't necessarily meeting the needs, and that the design of the corridors also were more reminiscent of like construction sites, and so were not being utilized or well received. So our program adapted, and what we heard was that speeding traffic, and I know communities around the country saw increases in speeding traffic with less vehicles on the road during COVID-19, and the need for people to access these essential places in communities. We launched our Essential Places program, which has been putting more temporary traffic improvements to support pedestrian crossings, but also really to improve safety for all road users near essential places and slow speeds down near those locations so people can access them during COVID. And that program has been really well received. And we have an interim report that is available on our website with respect to Slow Streets, since we know, there's not a clear end in sight for COVID-19, working to make all these improvements more durable, but also in response to what we heard from East Oakland communities. We received a grant from Smart Growth America to incorporate art into the Slow Streets program. And just a couple of weeks ago, we're really excited to launch like a planter box design that was designed by a local artist to kind of replace barricades with something that was more of a kind of a placemaking type of intervention for Slow Streets. So this program, we have a lot of lessons learned from the program. It's also really helping us, I think, with respect to understanding engagement and how we can better engage the most impacted priority communities to inform our transportation improvements. video doesn't work for everyone, so we're also pivoting to mailers. We just did a recent walking tour for a traffic calming program that we're working on. And I think since so many people were at home, doing it on a Saturday morning, we actually had people, kind of filtering out of their homes with masks to join the walking tour. So I'll stop there, as I know my fellow panelists have a lot to contribute. But I think that as you mentioned with this question, these disparities have always existed. COVID-19 has made them even that more visible. And as we work to address crises like COVID-19, the climate crises, these same communities are going to be most impacted. So transportation agencies knowing how to work with health agencies and community stakeholders to identify and elevate and address these concerns is really critical.
Yeah, Karen.
I'd like to pick up on the transit point that Wendy brought up in her talk, because we're really seeing transit being devastated financially through this process. And when COVID first came out, a lot of transit agencies were saying, don't ride us unless you have to. They were trying to be as responsible as possible. We didn't know a lot about the virus. New York City has had a few hundred transit workers die of COVID. So it's, it was a real concern. What we have learned since is that, with proper cleaning, with proper PPE, with people wearing masks and social distancing, transit is safer than we thought it was. And so there is a push now to try to get folks to ride it again. The circulation is better than we thought, or as we've learned more. But in the process, we have seen transit agencies first, tell people that they shouldn't ride, tried to make it safer by, particularly on buses, saying, come in the back door, you don't have to pay a fare. We want to keep our bus drivers safe, things like that. They've added extensive cleaning and buying PPE, and all that costs. So they're not recovering what we call fare box data. They're not recovering the fees of people riding transit. And at the same time, they have all these new costs about making sure everything is being cleaned, making sure they have the equipment. As a result, over 50% of transit agencies right now have lowered their service to lower than 75% of their usual service. And if they don't get relief soon, we're going to see a lot more of that. We're talking layoffs, we're talking less routes, cutting routes completely, or cutting the regularity of routes. And that's a real problem for essential workers, low-income workers, et cetera. If your bus stop doesn't exist now and you have to go 3 miles to get to your bus stop, that creates a real problem. If your bus now only runs every hour and you get off of work at 11 o'clock at night, maybe you have to wait till 12 o'clock for your bus to come, that's a real concern. And so that is something that is in the COVID relief at the federal level. It is something that we're seeing in the House of Representatives bill. It is not in what we're seeing from the Senate. There is a big push at the federal level to push for that federal funding, both to get to transit, as well as to get funding to state and local governments so that they can help with related services. And I would just say Transportation for America has really been leading that campaign. And so if you're looking to get involved, I would look at their website.
Yeah, great. Thank you so much. And Wendy, any final words on the COVID topic?
Well, I think everything that my fellow panelists have said is absolutely right. I think that one of the things that we've seen is the vast diversity in needs across the state. When you're looking at small rural communities and looking at what we have in Massachusetts, regional transit agencies are even more pressed than the big city transit agencies, although I think the issue is huge everywhere. But in terms of providing essential service, I think the other thing, which I mentioned briefly in my opening remarks, is drilling down to even some of the communities and people that are suffering from health disparities, even more so that we're seeing now emerge during COVID. And I think one is the population of seniors. Low-income seniors are in extreme, at extreme both risk and need. And I think some of the active transportation work in terms of thinking about walking and also access to transit, it's really important to drill down and really see the nitty-gritty. I'm sure that you're seeing it in Oakland, but it's something that we're seeing across the state, often in suburban communities where there are fewer choices greater distances, but very high need, as we know, a very large number of low-income communities and high need communities are in the suburbs. They're not in the middle of the city. So I think having the active transportation world think hard about how we respond to the needs that we're seeing as a result of COVID. They were there before, but now they're just exacerbated. So, and also I think the issue, which may come up later in the conversation a bit, around air quality and air quality testing and monitoring, and what are we really doing about that, and what does that expose about how we think about health and transportation policy looking ahead. We all saw, this huge drop off in emissions at the beginning during the lockdowns, those of us in parts of the country that were really locked down. But of course, those emissions are going up as there are more people out driving. But what does that mean long term? How do we really think about addressing that in a big way?
A lot of really great points. Thank you all for weighing in on that. I wanted to move now to a question that really stems from our first part in this series, which was a really wonderful discussion where our panelists have offered up a framework for how we evaluate power and privilege to help us consider how to address inequities in our transportation processes. And Renee, if I may start with you on this one, and then our panelists can jump in. Wanted to ask, what work are you seeing policymakers doing or needing to do in order to center voices of marginalized communities in policy discussions?
Sure, I can give an example. The most recent experience that I had working in a public agency, we were awarded a grant from the federal government, and a requirement of the grant was that our coalition needed to include a recipient of a service, which was, excuse me, a transportation service for a low-income person with a disability. So when we were putting the coalition together, I went to my supervisor and said, everyone on this coalition is doing this work as part of a salaried position that they hold, except for this person that is an actual recipient of this service. And I think we need to figure out some sort of stipend or other way that we can compensate this person for what they're bringing to the value that they're bringing to this coalition. And I was unsuccessful because the answer was our agency has a policy of not paying people for their time in that way. And I really feel that this was something that agencies need to look at and correct if they don't already have a mechanism in place, because we are asking for information. We are getting really valuable information about how to improve the way that we're doing work, but there are some serious class barriers that are in place that mean that we oftentimes cannot get the information that would really help us if we don't have a mechanism in place to pay people and compensate them for what they're providing to us.
Okay, I just wanted to jump in because I think Renee's point is really important, and point to the health care side of the world, health research, which is medical research projects are now required to have patients on the review panels for the research, and those patients are actually now compensated. They're not compensated at the same rate as, for example, the doctors and the researchers on the panel, which is a different question, but they actually have now formal systems for compensation. And I think we should look at that model as we think about what you just described, Renee, because I think, we can point to that. And that is, when the feds are paying for that medical research, they are actually paying for patient participation in those panels as a formal part of the work. So maybe we can find a way to start building on that experience.
Really good points. Anyone else have a response to that one? We can move on to the next question. We can always circle back to, I kind of wanted to shift to a part 2 theme in our series, which was all about collaboration and partnership. And during that episode, our panelists shared their experience about how they've built collaborative partnerships to improve coordination between health and transportation agencies. I wanted to ask you all, and Roy, I may ask you specifically from the state level, have you seen ways in which this type of collaboration between transportation and public health staff are shaping better policies, or perhaps examples in which policies really help to solidify that kind of collaboration? Maybe what you're seeing in your state and maybe others.
So Absolutely. One of the pieces that I mentioned in the active transportation plan was specifically that health component. So with the blessing of senior staff, which is important in a bureaucracy, I reached out to our sister agencies and started talking. We had a new WalkWorks coordinator. We had a very engaged conservation and natural resources person. We sat down at a table over lunch and kind of talked through what our individual visions were for this. Who had funding to do what parts of what program. PennDOT is usually looked at structural engineering, the things on the road, the maintenance of the road, DCNR's trails. And when we started talking about how do we make those decisions about where they go and who's accessing the trails and can they cross the street on the trails, it really became evident that three groups needed to come together, both for funding and expertise, but also to get the attention of our friends in the legislature. So the first thing we did was we had 5 different secretaries and deputy secretaries meet on a one-day session to talk in public about the challenges their agencies were having, addressing some of the equity goals and the health goals in the communities and what we could do to advance those. We ended up signing an MOU between Health, DCNR, and PennDOT to continue to work on developing walkable communities, and that has really transitioned through the CDC grant process. So we are able to give money to somewhere between 7 and 11 communities each year to do active transportation plans, create a Vision Zero plan or complete streets policy. And when they bring those to the table to PennDOT and say, this is the project we're scoping, here's what our community vision is, we developed a plan, there's a purpose for this connection, we need you to help us. We can do that now. It's not something that someone suggested, oh, they had a map back here. There's a complete plan. They've reached out to their community, and then they reach out to us again for multimodal funding. We're asking for them to talk about their community. How is this addressing equity issues? Who lives in their community? What are the health outcomes in their community? Tell us a story that makes a lot more comprehensive sense than, our sidewalks haven't been maintained for 15 years. We'd like to rebuild them. Why? So that narrative is getting out there, and all 3 agencies working together with educational resources, with staff training, things like that really moves the needle forward. Great
examples, Roy. I wanted to ask if the other panelists have sort of those any examples they've seen of that collaboration partnership being a central focus. Yeah, Megan, yeah, please.
Yeah, thank you. Just similar to my introductory remarks, just commenting on, I think, Vision Zero was in San Francisco was one example, but I think through through our work on Vision Zero, I kind of came up with, we identified some clear buckets where, that health partnership with transportation agencies can really help advance and support collaborations towards mutual goals. And I think some of those buckets include, collaboration on data. And so health agencies having access to data that transportation agencies might not have access to with respect to hospital data and opportunities to creating more comprehensive data systems. I know this was a theme in the earlier, one of the earlier webinars, but that being a really valuable, partnership, interdisciplinary wise. Also, health department representatives as spokespeople. So for example, in advancing automated enforcement policy at the state level, we were able to work with trauma surgeons, to speak from their experience as medical professionals as trusted spokespeople on policy issues, and even actually had a press conference in the lobby of our hospital, speaking to those issues. Also, really partnerships. So public health agencies often work with community stakeholders and have maintained health clinics where a lot of the same populations that are experiencing some of the most negative health outcomes are receiving services and are actively engaged in and there's a real opportunity there with respect to the outreach and engagement that everyone's been talking about as so critical to informing transportation and health policies. And also, really leading with equity. So core to missions of public health is a focus on equity. So really that having that value be brought front and center to the table for these discussions.
Great, thank you. And Karen, yeah, please.
Yeah, I just want to second that. We've definitely seen in communities, different communities have different relationships depending on different departments. But one of the things we've seen is that health departments, as Megan was just saying, are usually in the community long term, and so may have a stronger relationship, where transportation, by its nature, we come in, do a project, and maybe move on. And for something like bike lanes, which can often be seen as a gentrification concern, having the health department come in and do a little more of a scope on active transportation and what you're looking for can work better, and sometimes because that relationship has already been built, than say someone on the transportation side who hasn't been in that community as long or as recently.
Great points. I'd like to move us to our part 3 theme of our series, which was really a detailed discussion about data integration, kind of linking health and transportation data. We discussed those ways in which integrating those health and transportation data can lead to new insights and tools for decision makers. Wanted to ask you all, and Renee, I may start with you if that's all right, if you're seeing policymakers utilizing these more robust sources or data, and maybe what data are being used and are most needed to inform policies related to transportation and health and equity from your view.
Sure. Normally, my best example is Vision Zero from San Francisco, but with Megan on the line, I can't really use that one. I would give an example of a project that I started and wrote the grant for, but had left the agency by the time we actually implemented it, which was we were given some grant funds to test a concept of providing transit tickets to folks that had a history of missing healthcare appointments, to try to prove that if you give people transit passes and they have a way to get to an appointment, they will actually follow through more successfully than they had previously. But the problem was we had to have data to show that outcome, and the public health folks will know it's kind of hard to show a health outcome in a 6-month pilot. You usually need more time than that. So the solution that I hit on was taking advantage of something that's called the Healthy Days tool. So it's a CDC question module that's probably been around at least 20 years, maybe 30. It's national. You can slice and dice data and compare it in different ways. And so what we said was, let's ask the folks in this study. We'll ask them a question. We'll ask them these 4 questions at the beginning, before they've ever, received any benefit, midway through, and also at the end. So we'll have not only the data of the population in the intervention, but we can also do some really robust statistical comparisons to look at this focus group compared with other folks that may have similar, age, ethnic, or geographic similarities. And so taking advantage of a really large and valuable existing data set and being able to do that comparison really helped, so that in a program that only had maybe 100 to 120 different respondents, we were able to show a statistically significant impact on self-reported health data just in that 6-month period. So that really helped in terms of proofing out, yes, the intervention that we developed is something that is really valuable for folks, and providing subsidized access to transit is something that has a demonstrated health outcome.
Great. Yeah, Wendy, go ahead.
Sure, and I just put in, I think it's the chat that only we can see, so maybe you can share it with the full group of participants. There is a brand new study that just came out of the Harvard School of Public Health, literally within the last 2 weeks, where they looked at the range of outcomes from a variety of very significant interventions. The Northeast of the United States is having a conversation right now about something called the Transportation Climate Initiative, TCI, which is essentially carbon pricing. Pennsylvania is absolutely part of that conversation. And what this very large new study looked at was which interventions in the transportation system, which investments, if you took the money that came from the carbon pricing, which investments would have what impacts on public health. And the findings from my perspective, are fascinating because when they looked at an investment policy that put more money into transit, walking, and biking, the health benefits of that was larger than if you put the money into electric vehicles and that system, which is something that is a big debate right now in the transportation world about how to get bang for the buck in terms of GHG reduction and health, which of course those two things are absolutely linked. But so if you share that with everybody, that is something, it's very interesting. I think it's perhaps the first study of this scale that looked at that trade-off between different kinds of interventions in the transportation system, if you, what the outcomes on public health would be. So I don't know yet, I don't think any of us know yet how this is going to shape the debate as it goes forward. But I think from the active transportation side, we have been saying for years that interventions in active transportation and transit have a very big bang for the buck because of the combination of reduction in emissions and physical activity. And I think, and of course, reductions in crashes and injuries as well. So I think that's really important. And I think another area that from an active transportation point of view, we have not spent much time and energy looking at data on. There is some work, but that's on falls and fall reduction. That is the biggest mechanism of injury that hospitals see walking into for treatment for trauma. And the investment that public agencies and transportation agencies and public works departments are making in smooth sidewalks and really, you know, a very connected network for people walking hasn't really been looked at as a significant public health intervention. And so there, I would love if anybody on the call has information that they've seen where people have actually put money into that very specific issue. It would be great to see, but my sense from thinking about, maybe Megan, maybe you do, and maybe San Francisco did, but I think that is a big intervention that the active transportation community has not yet taken a deep dive into in terms of data.
Megan, do you want to share any more about that?
Yes, I have so much to say about this, the data example, but I'll restrain myself. But I'm, you know, I think, well, I know in San Francisco, the Vision Zero goal really actually helped create demand for a better data system to inform injury prevention. And you know, through that work, we were able to, and I know my colleague Shamsi Sultani presented on some of this work in an earlier webinar, you know, link the hospital and police data to have more comprehensive data, which was really critical because we know, you know, even in San Francisco where there's a really active advocacy community, you know, around reporting that injuries people walking and biking are significantly underreported, you know, using only police data. And that there are differences, but you know, by race in that underreporting. But to Wendy's point, you know, from a broader public health perspective, I feel like these types of data linkages with trauma center data, right, and police data or any other data source has so much potential beyond injury, you know, beyond traffic injury. You know, to you know, a deeper dive with geocoded data on, you know, on falls, looking at, you know, another really important issue is, you know, gun violence and better understanding intersections with you know, community violence and traffic safety. So these types of robust data systems and partnerships, you know, with transportation agencies and health organizations really lay a foundation that just has so much potential to build upon. And another example, you know, from San Francisco was e-scooters, where you know, they, as I think many know, you know, they descended upon the city very quickly, and then immediately raised a lot of questions with respect to injury. And through our partnerships, including with, you know, with UNC, we were able to, you know, locally, we worked with our trauma surgeons to develop a methodology to immediately start capturing information in hospital records, but we're also able to simultaneously advocate, you know, for changes to the ICD-10 hospital coding system, which was actually rapidly adopted and is being implemented now. So those types of injuries can be captured nationally. So partnerships have immediate benefits with respect to data linkages, et cetera, but also just really creating critical relationships to help us better understand distributions of health impacts for things that we can't really anticipate.
Yeah, Wendy,
can I just add one?
Sure.
Sorry, can I add one more piece to this? Because I think America Walks is in the very beginning stages of trying to collect data on sidewalk policies around the country and connect that with what we see in terms of injuries. I don't know that we're even close to connecting that with falls, because I don't think we have the data yet. But the policies about who's responsible both for building and maintaining sidewalks vary enormously across the country, from it being a municipal responsibility to being the responsibility of the private property owner. And I think that's another piece of data from an active, at least from a walking point of view, not so much obviously from a biking point of view. It's a very important data point that we don't really have good information on. So again, if anybody on the call has information about this, we're really trying to do a broad look at that question, because I think it's very important to, as we think about the level of investment and what that means in terms of public health, both physical activity, injury and falls.
Those are great points. I actually wanted to sneak in, if I could, a follow-on question for Karen. Karen, I couldn't help but notice on one of your slides, you mentioned among your lessons learned in working with policymakers is to, I think I wrote it down correctly, is you want to use their language. And I often find, I think all of us do with data, it can be especially complex to communicate maybe what our data are showing. And I wanted to ask you kind of the languages around health and transportation, especially with respect to data, which can be the most difficult to translate to policymakers, and how can we do that in a better way? Because we often as researchers don't know how to talk data to people who maybe aren't knowledgeable about it or know where it's coming from. And I think policymakers are really the ones who are going to take it and make action with it.
Yeah, thanks. And we do see with the health community, having that evidence-based data is actually one of those sort of buzzwords, part of the language that we're looking for. When we're talking about transportation and data, it's interesting because we don't always collect all the data for all the modes when we're looking at transportation policy. So for instance, when we're talking about a lot of these safety issues and where states spend their safety dollars on transportation, they really sort of focus in on what they call hotspots. Well, where you see in-vehicle fatalities and serious injuries are generally like a head-on collision at an intersection or high speeds. But the places that are dangerous for bicyclists and pedestrians are generally along a corridor. A collector road, an arterial, where you've got high speeds, but you don't have the infrastructure. And those just don't get collected. And so they don't compute into the data-driven state decision-making. And so that's another thing we need to think about with data and how we translate that to decision makers. Not only do we have to figure out how to integrate the health data that's being collected with transportation data, but also which data is collected. And again, like hospital data doesn't match the traffic data that departments of transportations are looking at. So that's just another example of where we need to figure out how to combine data.
Yeah.
Dan,
Renee?
I know you're trying to move us along, but there's some really fascinating technology with artificial intelligence in camera images. So where the camera is already capturing something for like red light or speed enforcement data, how can you see the sort of near misses of crashes so that you don't have to wait for something terrible to happen before you have enough information to make some policy decisions?
Great points.
One more, quick thing is we are seeing scientists use virtual reality to ask people, are you comfortable walking here? Are you comfortable? And we've also seen people wearing bike helmets that, I don't know if they get your heart rate or what they get, but they can tell sort of your level of stress. And thinking about those levels of stress, whether walking or biking, could really help us with transportation and also where people would be willing to bike and walk, which affects how much physical activity they're getting.
Definitely. A lot of promise with technology with respect to data. I definitely agree with that. I wanted to get to a couple more questions that I have pulled together here. Roy, you may be in the best position to start this one, and then we can circle back around. Yesterday, part 4 of this series was all about prioritizing and ranking transportation projects to kind of reflect health goals and incorporate health into prioritization for transportation projects. At the state level, I imagine you've got a close eye on how funds are distributed and priorities are set. So I wanted to ask you first, say that prioritization methods often do reflect broader agency priorities and policies. So I wanted to ask how you're seeing health considerations being integrated into these kinds of larger policy initiatives and how projects are funded and prioritized across the state.
Sure. So at PennDOT, we kind of have 2 levels of thinking about this. The first level is grant funding, which I think I've mentioned before, where people are coming in with a project and they'd like to get our funding support for it. Starting to have those discussions with our applicants, asking, the story behind their project, what's it going to do, who's it going to serve, and then ranking their responses. And what we've seen, at least in the Transportation Alternative Set-Aside program, is that the applicants are becoming better at that. Also in the WalkWorks program over the past 3 years, they're beginning to understand that just giving us a percentage of people, of minorities, and then a percentage of car ownership, and then going on with their story is not enough. They're really starting to say the regional hospitals community health needs assessment says this, and this is the percentage of people with obesity, and this is the people with diabetes, and they live here in these communities, and they're starting to understand that language, starting to become embedded in the process. And through the funding we do for active transportation plans, that's what we're asking them. Our how-to guide and our local technical assistance program are also pushing them in that direction when they're thinking about active transportation. Some of our smaller NPOs are trying to do that kind of equity analysis for their transportation, and they're struggling because the data resolution isn't quite fine enough for that. They have county level data pretty solidly, but if you've got a borough of 1,500 people, you're not going to have enough data points in there to really be able to tell a story specific to that location. So they're struggling a little bit with it. They are working with federal data to get an idea of what a common consensus is on vulnerable populations and minority communities, so everyone's talking in the same language. I would like to point out, just with the other question, that there is some research coming out that talks about best practices for collecting sidewalk data and how different DOTs are doing it and how to store it and have a repository and a common data dictionary. So that information is coming out there, and it's really hard to collect that data. But overall, we're seeing it. We did that work a little bit in our active transportation plan for equity and health, and it's coming. We're not as comfortable at PennDOT putting the health piece into our project selection. We're really focused on the safety part of health. So the crash clusters, improving consistency in design changes. So where there's a pattern of crashes at a series of intersections, it worked done all across the state. We reduce that. We fix it as we go everywhere. So it's a systemic approach to improving the problem. It's not health focused exactly.
Gotcha. Thank you, Roy. And Megan, you've got some examples of project prioritization in Oakland. Do you want to share?
Yeah, Oakland's capital improvement program has a number of criteria that are used to prioritize the programs and projects that are advanced and prioritized, including safety metrics, as well as some health metrics that capture climate and air quality related impacts, additional metrics looking at potential displacement, as well as the priority equity communities that I mentioned in my opening remarks. So I'm sharing a link to that for people who are interested more. But I think just back, echoing a lot of the themes of this discussion, really having the data so that it can be used to help prioritize is really critical.
All right, thank you so much. I wanted to get to a question about, and it kind of builds on one that we just touched on a bit with technology, but it has to do with disruptive technology and vehicles. There's a lot here, so I'll say it and then please jump in if you've got a response. There is considerable interest in emerging and these potentially disruptive technologies. We're talking about everything from e-scooters and e-bikes to sidewalk delivery robots. How do you all see these innovations in terms of their potential to support healthy and equitable transportation? Or maybe what unintended consequences might there be and need to be a bigger part of the conversation around these technologies? Renee, would you like to start us with that? And then we'll go around the room. I think everyone's...
Let me, I see Roy is anxious. Let me let him jump in first.
Okay,
and I'll
sure.
go after him.
Okay, so when you're talking about micromobility, the universe of micromobility is pretty large. You think of e-bikes, you think of bicycles, skateboards, power skateboards, hoverboards, e-scooters, non-electric e-scooters, and a range of other things you can buy at Target. This is micromobility. It is disruptive. What it is doing is basically unpacking the services that we are traditionally anticipating having when we buy a car. So you have short trips. I think it was San Francisco that just released the data that showed e-scooters were generating 4 times more transit trips than they were replacing. So they're a first last mile to transit. It's a great piece there. There's a lot of confusion in the world about safety, about regulation, and a failure to differentiate between private ownership and mobility as a service. So a ride share system that provides scooters. And they would very much like in the legislature in Pennsylvania to see insurance provided for those companies. So we don't have e-scooters in Pennsylvania legally, but people are riding them now. The real challenge is, can we get the infrastructure in there? Can we figure out how they interact? Can we design? For me, it's more of an infrastructure problem than a policy problem. The health connection is that it gets people out and moving. It gets them out of the cars. It reduces the greenhouse gases. It reduces the number of cars we have to build, which is also very critical for greenhouse gas and global warming to start with. So it's a huge deal. The legislators are struggling with it, which is probably better because the DOT is struggling with what does that mean? We're not counting the numbers of them. We're not counting their vehicle miles traveled. We don't know how to count their crashes. We don't know how to classify them. It's a big problem because it's a disruptive technology, but it is here and it's coming and it's going to be amazing.
Great, thanks so much, Roy. Who else would like to jump in? I see hands all over the place. So
Yeah.
how about Renee and then Karen and then Wendy? Okay, go ahead, Renee.
Great. I'd say in general, obviously I work in technology, so I'm pretty pro a lot of the emerging and disruptive technology. One thing that I think is really important to consider is I think it's really opened up how we, maybe in the more traditional professions, think about disability. So a lot of the ADA or Title VI is more around wheelchair accessibility. And you guys might have seen NACTO did a really fascinating video this summer about all the different ways that bikes are accessible technology or accessible modes for a very wide variety of different kinds of disability, whether it's physical or behavioral or intellectual. And so I think it's a great opportunity to expand what are the barriers that this technology is causing and what are the opportunities that it's creating that haven't been addressed by the modes that we've had in existence before. So these are really thorny and complex and complicated questions to answer. And I think we should be doing this anyway, but particularly because of this, we really have to be careful, those of us that have like some level of industry experience and networks, that we're thinking about who am I talking to? Where am I getting my information? Do I have diversity of input? And if I'm in any position of power, whether it's like hiring people, putting coalitions together, or just, you know, things like being asked to sit on the panel here, you know, how am I making sure that my network isn't just, you know, people that I went to school with or that sit in my department, but I am diversifying my network so that folks that have historically not been included in these conversations, whether it's about planning or health, are coming to the table, we're benefiting from them, and we're giving up some of the power that we've already accrued in order to deepen the conversations and do a better job of incorporating this new technology to create a more equitable transportation system.
Great points. Karen, why don't you go ahead, and then Wendy, we'll let you wrap it up.
Yeah. So first, I just want to make a health point on e-bikes, and that studies have shown that people who ride an e-bike versus a regular bike are basically getting the same health benefits, because people on e-bikes are more likely, they're likely to bike more often and bike further. And we do see it as a great way to extend physical activity for people as they get older or with certain physical limitations. On the policy side, I do want to say we are working on a bill in Congress that would start a task force at the federal level to look at all of these questions that we're talking about. And the way it's written now, it would also include some compensation for folks who are able to do that.
Thank you. Wendy.
Thanks. And I first I want to say that basically I agree with the things that people have said. Whoops, I think we lost Karen. Oh, you're back. I think one thing that we really need to keep in mind, and I'm absolutely speaking with my walking advocates hat on, is, I don't know, all of us know the phrase context sensitivity. We spent a lot of time working on that for road design and sidewalk design, and I think the same is true for micromobility. So what works in terms of sharing space between people on foot and people using micromobility on a rural trail or a sidewalk in a low density suburb is really different from what works on some of the incredibly crowded multi-use trails that we have in Massachusetts or the crowded sidewalks of more densely settled cities. And I think the issue of mixing speed is one that we take really seriously, and one that we get a lot of complaints about from people, especially older adults, who in some cases are telling us they won't go to certain parks anymore because they feel like they're going to get run off the road, so to speak, run off the path by bicyclists, and in particular, you know, e-scooters and then bikes that are traveling at higher speeds. I absolutely agree that some of the micromobility opens up different kinds of transportation options for people who don't have them, and I think that can be wonderful, but I also think that we have to be really careful in considering what this means. There are a lot of urbanists that talk about sidewalks. It's like the only place that pedestrians get to let down their guard, and I think that is a really, really important piece of the system. And again, with the aging population in the United States, that's a population that is not happy to have people going by them faster than walking speed. Or running is okay because runners can pretty much stop on a dime, and that's not true for micromobility. So just putting that out there. So Karen, when you put that, when that advisory panel gets put together, I think having older adults, pedestrian advocates, people from the disability community on that panel is going to be absolutely critical. I don't know if there are criteria about who would sit on it. Thanks.
Yeah, there's two spots, one for older adults and one for people with disabilities.
Yeah. Megan, you had a final word? Oh, you're on mute, sorry.
No, thank you. I'll keep it super short. Thank you, Dan. I just wanted to say, I think it also, you know, comes back to the issue of what are the goals, you know, of our communities, our jurisdictions with respect to safety, health, and equity, and really viewing these technologies through that lens. And you know, how are they potentially advancing those goals, or what are you know, threats to equity and more vulnerable communities, and looking at technologies through that comprehensive lens.
Great. Excellent. Well, I am really in the unfortunate position to have to be the one to cut off the discussion today, because I think we could keep going for a very long time. We have such wonderful perspectives on these issues, and I appreciate all of your time weighing in on these questions and sharing your stories and your experience. I put up on the screen, and we've included it with the slide deck, some ways to get in touch with our panelists and to get in touch with us. If we can help relay your questions to the right people, we'd be glad to do that. I think that as we're hearing, there's work being done on this now and will be into the future, and there's really probably no shortage of opportunities for you all to get involved, no matter what your position is. I hope that the series has sort of illustrated a few ways that you can engage in this connection between health and transportation and help move things in the direction that we're seeing, recognizing as a priority. And so I'm glad that you all were able to join us for this webinar series. You'll get an email from me later today with a lot more detail about where you can find the archives and more materials that we shared. I want to just say a big thanks to Renee, Wendy, Roy, Megan, and Karen for your participation and your time today. And thank you all for joining today's webinar. Hope you have a wonderful day, and we will see you next time. Thank you.